Pediatric emergencies. So, like I said in lecture, the leading cause of death in children and adolescents is what? Unintentional injuries. Falls are the most common cause of injury, and automobile accidents are the most common cause of death. And most pediatric cardiopulmonary arrests result from respiratory failure or shock, and children that have to go through resuscitative measures don't do very well. They don't have a good prognosis. Information about child abuse and neglect. The incidence is, they've estimated that more than 40 per 1,000 children are abused, and that 4,000 children die annually from child abuse. It's also called child maltreatment, and it includes any physical, sexual, emotional, or psychological or other damage involving a child with intent to harm them. Child abuse can take the form of physical abuse, emotional abuse, mental abuse, sexual assault, or neglect. Obviously, physical abuse is an action by a caretaker that results in an injury to a child, but it could potentially be non-accidental. Well, it is non-accidental. Physical neglect is omission and a failure to provide. So either you're just not providing the things like food, shelter, clothing, medical care, and a safe environment, or someone else, like the father or the mother, is not doing that, and you're allowing it to happen. Emotional neglect, we have to meet the emotional needs of children. Sexual abuse involves any activity meant to provide sexual gratification to the adult. So it doesn't matter what you did to the kid or what the person did to the kid. If they meant to be sexually gratified by it, it is sexual abuse. We talked about the characteristics of a child that's been abused. They can have behavioral extremes, one to the other. Serious withdrawal all the way to really aggressive. They're going to have inappropriate maturity. They're going to try really hard to control things because they have a lack of control at home. They might not want any adult to look at them or talk to them, but then it could also be the extreme where they are far too friendly with everyone. They might not cry when they have painful procedures done, and they just don't have a good overall self-concept. For an adult to be an abuser, if they have a history of being abused themselves, it's highly likely that they will abuse. If they have a history or a current use of alcohol or substance, if they're undergoing extreme stress due to financial issues, relationship issues, workplace issues, family issues, if an adult that has given birth to a child who is premature, that is stressful. A child with cerebral palsy or other chronic illnesses or diseases, a child with an intellectual disability. Poverty and chaos also can lead to physical abuse. I think, again, those are areas where we're looking at the stress level of the parents. So what you're going to look for is burns, cuts, scratches in areas that are normally covered by clothes, and bruising on the chest, the neck, the head, like the side of the head is a big one, or the back of the head. Those are not normal areas for bruising. If caregivers are interviewed separately about their child and they can't tell the same story, that's suspicious. If they wait days to bring their child in, if the bruises are healing, if the broken arm is days old with lots of swelling, if the child has been sick and dehydrated for a week and has never been brought in, if the child has been seizing and obtunded for a couple of days and they don't bring them in, that's very suspicious. They usually wait until the very last minute when the child's almost dead to bring them in. There's burns. There needs to be a clear delineation. So, like if I took a hot object and placed it on the child. So, if a child's just reaching for a thing of water that's hot or a coffee cup that's hot, there's going to be splattering, right? If it falls on them. In a burn that is inflicted on the child, it's usually a very clear, specific pattern with no splattering. um, we talked about sexual abuse in class. We have to look at a high incidence of STDs or STIs, a high incidence of UTIs, hurting themselves or others, suicidality, investing in high-risk behaviors and inappropriate sexual behavior. They could regress. Kids that go through emotional abuse, we talked about them as well. They're going to have low self-confidence. They're going to have a lot of sleep disturbance, headaches, stomach aches, and they are going to be hypervigilant. They're always watching for that thing that they do to happen that makes them get yelled at. So when we're doing an assessment for children that we might think could have been abused, we want to ask them, are you afraid of anybody at your house? Do you have anybody you could tell if somebody hurt you or touched you wrong or touched you badly? Has anyone hurt you recently or ever, or touched you in a bad way that made you feel bad? And then we also want to ask the parents that. If we have them separately, we want to ask both of them, are they afraid of anybody at home? Do they ever feel like they themselves might get too frustrated and hurt the child? Talk to you guys about Munchausen syndrome by proxy. There's not a lot of good evidence-based research showing that that is an actual common occurrence. It happens so infrequently, but parents get accused of it all the time. You can look it up for yourself. Parenting responsibilities are to be aware of our own feelings. We have to be non-judgmental. We have to just do our job, refer to the child welfare services, and report what we've seen. That's it. For safety, until the child is 40 pounds or more than 40 inches tall, they need to be in a rear-facing car seat. That means in the back seat, in the middle, facing the rear. If they're in a front seat, that's fine, but what do they have to do? They have to turn those airbags off. So 40 and 40 pounds or more than 40 inches tall, then they can get out of that rear-facing car seat. They can be in a booster seat from that point forward until they are 8 years old or 4'9". That's going to do it. Do it. Water safety, again, keep it simple. We don't want things that they can fall into. Toilets, bathrooms, sinks left alone in the sink in the kitchen because they can sit up themselves. Great, you're giving them a little bath in the sink, but they could still drown in there. Mop buckets. And we need to put fences around our pools, right? And they need to be fences that are locked, because if there are older children that have access to those locks or to the gate itself and can just open it, then they might be the thing that causes the smaller child to get into the pool area. About this, go on to the next. Going back to sleep, encouraging breastfeeding, no pillows, no fluffy things, no quilts. There need to be tight-fitting mattresses with firm, tight-fitting sheets. No co-sleeping. The foods the babies should not have, and think about why they shouldn't have them. What way can they have those specific foods, if at all? Um, so pay attention to the questions so that you know exactly what it's asking you. We're not saying that a baby can't have carrots ever. but a baby can't have chopped rounds of carrot. Zone picture right there, that younger children are at a higher risk for pedestrian injuries in parking lots. 67% of child pedestrians aged 2 to 10 in parking lots were unsupervised. 89% of children were outside of an adult's arm's length. So an adult could not have grabbed the back of their shirt and pulled them out of the path of whatever car is backing out. They're not close enough. 50% of children exited the vehicle prior to the adult. I know I used to fuss at mine all the time. I get you out. You don't get you out. Thank you. We are a little controlling, but it keeps them from getting smashed in a parking lot. Think about poison control and how that affects these kids, what we have to do with that. We need medications to not just be in child-proof bottles. We need them to be out of the reach of the child completely. We can't just leave grandma's pills in her purse with the purse on the table when she comes over to visit. We need to have those sorts of things hung up and out of the way. Can't tell you how many kids I've taken care of who to be placed into a coma because they swallowed all of grandma's metformin. It's horrible. So even if it's not a drug that, like a street drug or a toxin, poison control needs to be called for medications as well. Guns. We talked about this, and Michael was lovely enough to tell us all exactly how that should work. Student Michael, he said they have to be the gun in one locked cabinet, the ammunition in a completely separate locked cabinet. They cannot be together. Let's talk about the car safety. Preschool to 4 years, they can be front facing. Usually by the time they've hit preschool, they are about 40 pounds. They can be front facing with a harness, and the seat has to have a top tether. If they're going to be in the front seat, again, they have to deactivate the airbags. These kids, think about the fire safety, matches, lighters. They have the dexterity now. And water safety, because they know just enough, and we've taught them to swim, and they think they're great. So they don't recognize the issues and the concerns and the consequences of jumping into the water unattended. Bathtub temperature below 120 degrees. So you have to change the temperature of your house water when you're fostering a child that is under the age of 10. They come in and they check the temperature of your house water. They want to see that it's below 120 degrees. So everyone should know how to do that, to turn their water heater down before they have children. Back seat, even if they're able to be out of a car seat, they should be in the back seat until they're 13 years of age. And this is because of their size and the way airbags work, the way they can hit their head on the dashboard. They need to be in the back seat. So just kind of think about the anatomy and physiology of the whole thing, where they're in a car and it's crumpling in a front end collision. That's why being in the back is the best. So at about 13 years of age, we assume that the shoulder belt on the seat belt, the shoulder strap, is actually fitting them at the place that it's supposed to be fitting them. So it's another good reason why they need to be in the back seat. We need to teach our kids, when they use crosswalks and sidewalks, to put their phones down and not have headphones on. They're going to get hit by a car because they're staring at their phones or they're playing with their music. They need to wear helmets and appropriate shoes when they're riding bikes, and they need to follow traffic rules. No child should be on an ATV until they're 16 years old. There's a teacher at BC, and her son received a spinal injury where he was paralyzed. Well, she might not be there anymore. She was one of my teachers. He was riding an ATV on their family farm when he was about 13, and it went into a ditch, and it broke him right around the thoracic spine level, so he had quite a bit of paralysis. Um, we need to teach kids not to run around the pools. No running. It's so annoying when you hear the lifeguard saying that, but it makes good sense. Drains and covers on the drains. The drains in the deep end of the pool, they need to be covered, and kids need to stay away from them. And we need to teach them not to dive or jump head first in the shallow end. We get a lot of neck injuries and concussive injuries because of that, and then they can drown. Drinking, drugging, having sex. But the leading cause of death is motor vehicle accidents. And sorry about my throat. The second is poisoning from opiates. It is in chapter 40 on your book, which is page 1434. Most children, usually between the ages of 6 months to 3 years, this is where foreign body aspiration happens. It occurs when any solid or liquid substance is inhaled into the respiratory tract. So we're looking at peanuts, Legos, coins, really thick, grody mucus. The object's going to lodge in the upper or lower airway, and then they're going to have varying degrees of respiratory difficulty or insufficiency. Some of the cues that we're going to see is a sudden onset of cough, wheezing, stridor. If they're having stridor, this means it's upper airway obstruction. When the item has traveled down to the bronchi, you're going to hear wheezing, bronchi, and there's going to be decreased air movement on whatever side of the lungs is the most affected by the obstruction. So if we do an assessment, because our hypothesis is that they have a foreign body obstruction in their lower airway, likely we would hear no breath sounds on one side of the body. So the therapeutic management for this is we have to immediately dislodge it. Sometimes we can't do that though. So we try with chest and back thrusts. We try to dislodge it with our fingers if we can see it, but we don't do blind sweeps. We can bring the child into the hospital and do a bronchoscopy, and then they have to stay in the hospital for a couple of days, usually about 24 to 48 hours, so that we can see if any laryngeal edema and or respiratory arrest happens. We give them antibiotics if there's an infection present, like my stepson, and he stuffed that peanut in his nose, and it was there for 3 weeks. Goodness. So, some of the actions we're going to take as nurses, if we know that the child is obstructed and there's no airflow, we have to Heimlich them. If they're less than a year old, we have to do the 5 back blows and then 5 abdominal thrusts. If they're unconscious, we have to start CPR. And we're going to try to see if the foreign body is there or able to be visualized before each ventilation, because we don't want to push it down any farther with our breaths. We don't blind sweep. We watch for edema. We monitor them. We withhold the liquids until their gag reflex is back and can be tested. And then we want to assess the parents and see how much education they might need. Labs or diagnostics we might do. The only blood test that we might really need is an ABG. We might do an X-ray for ruling out pneumonia and to see the foreign body. And if we're concerned about infection, that would be when we do the CBC, but it's not completely necessary. The most important intervention is prevention. So we want to tell parents, If the child is less than 3, avoid all toys that could fit inside a toilet roll holder. So you've got your little toilet, your cardboard toilet roll thing, the little hole that's there that you can look through. If you can fit a toy inside there, it's perfect sized to get stuck in their airway. We don't give popcorn to any child under 3 years old, and we chop all solid foods that they're small enough to pass through the trachea. Inflammatory response, an IgE response to an allergen like nuts, shellfish, eggs, bees, wasps, medications like penicillin or NSAID. Even the radiopaque dyes that they use in CT scanning can cause these responses. There was a person who died at Kern Radiology about, I don't know, I want to say 7 years ago from a reaction to the dye during a CT scan. You can also have an allergy to latex that causes anaphylaxis. Anaphylaxis starts within 5 to 10 minutes of exposure to the substance. It includes the skin, the heart, the lungs, GI, and the neurological system. And you see severe vasodilation, which leads to circulatory collapse. It sounds like a type of distributive shock. So an allergy, we have to educate parents and patients that they have to avoid cephalosporins. So psyllins and cephs, they run in the same family. So if you're allergic to one, you should stay away from the other. If you have a latex allergy or your child does, these are the gajillions of things that they might have to avoid. There are some evidence-based studies that have been being performed showing that small and repeated exposures to allergic substances can over time decrease the response. But that's a scary place for a parent to go, right? Shock as respiratory or hemodynamic compromise with impaired CO2 and impaired systemic vascular resistance. The types of shock that we are going to talk about is hypovolemic, septic, and distributive. Hypovolemic is the most common one in infants and children because it's due to vomiting, diarrhea, heat stroke. All those kids that car seat safety, don't leave them by themselves. They get stuck in the car and they die from heat stroke. Um, Kids that have blood loss from injury after a motor vehicle accident, or kids that are third spacing that have cancer and or burns, and they require that albumin to bring the fluid back into the vascular space. So hypovolemia, super common in kids. Septic shock is an inflammatory response. Uh, Distributive is a loss in systemic vascular resistance. So the hypovolemia leads to swelling or vasodilation. So then you have big open spaces and it requires more output. Anaphylaxis is a type of distributive shock. So like I said, distributive shock is big open spaces get created and it requires more output. Infants and children their little hearts have to beat so fast to have more output because they have a smaller stroke volume. They don't have enough space in their chambers to fill up with a lot. So what they're pushing out isn't as much in comparison to an adult as we're pushing out. So their cardiac output is dependent on their heart rate, not their stroke volume. It's a good idea if you guys look at the early and late signs of distributive shock. I'm not going to test you on this, but you do need to know that tachypnea and tachycardia are early signs. They can be super warm. They don't have to be a cold, shocky kid. It's a late sign when they get that thready pulse, the cyanosis, clammy skin, bad. Bulimic shock, look at those clinical cues. Dry mucous membranes, depressed fontanelles, cold, clammy skin, scant urine production, and reduced capillary refill. This is what I want you to know about the actions that we're going to take if a child has shock. You need to know how much and what kind of fluid we're giving. So, hypovolemic, we're going to bolus them. Remember, we bolus on pumps. We're going to bolus them with normal saline and then blood if they've hemorrhaged. We're going to give it 20 mLs per kilogram over 15 minutes. And we might do that 2 or 3 times. If they are septic, we're going to bolus them with the same amount of fluid, 20 mLs per kilogram over 15 minutes. But then we also have to treat with antibiotics or epinephrine or something to improve their heart rate. So this in septic shock, we're going to be treating underlying causes, whereas in hypovolemic shock, we're just trying to fill their pump. Distributive shock, look at that again. It's still 20 mLs per kilogram over 15 minutes. So this should be a clue for your testing. It doesn't matter what kind of shock they have, they're always going to need 20 mLs per kilogram over 15 minutes to increase their intravascular volume. The nursing actions that we might take, we have to do our ABCs first. We have to do our ABCs first. Airway, breathing, circulation assessments. Then we give them IV access. The femoral route is really great for central access while someone's up at the top of the child doing CPR. If you can't access that, you do an IO, which is the intraosseous. The usual site that we use on a child for IOs is the anterior tibia. It's scary looking, but some people really like to do it, and they're very good at it. I am not a fan of it. I'm not very good at it. Those are interesting. So after we have done our ABCs and established access, we assess their fluid status. We do their eyes and O's. We do their level of consciousness. And then the things that we watch for to see if we have gotten some evidence of a good outcome. We want to see improved cardiovascular status, that their pulses are stronger, their cap refills improved, their BP has improved. We want to see their level of consciousness and their mental status improve. And we want to see their urine output improve, but we might not see that immediately, right? That might be something we have to assess over time. Very frequently, we have to bolus kids more than just once or twice. So keep that in mind. If you're still not seeing the indicators of improvement in your outcomes, you might need to go back to the beginning, do the ABCs first, make sure your access is good, and assess their fluid status. So some of the actions that you would take, we want to know that about a 3-year-old patient received from EMS into the ED who was found floating face down in a neighbor's pool. We want to know what history you need, what information from EMS, and what complications might arise. So when we talk about near drownings and submersion injuries, the things we have to figure out is where it happened, what type of water it was, and the temperature of the water. Why would you think that's important? I would hope that you would understand that the type of water, if they're in a pool versus in a lake, What we need to do to treat them is going to be different. They're going to be more susceptible to bacterial infections, fungal infections, amoebas, all of those nasty gunks if they're in a lake rather than a family pool. We have to worry about the pulmonary edema that might occur because of the chlorine in the water, just the water itself. But we need to know what type of water. The temperature of the water is important to know because if that child comes in cold, we need to warm them. We have to rule out any injuries that happened. If they were in a pool, did they fall, hit their head, and then end up in the pool? Did they jump off a diving board, hurt themselves, and end up in the bottom of the pool? Did they fall off of a jet ski? Because we might need to pay attention to head injuries as well. We need to know if they were conscious or unconscious when whoever saw them in the pool found them down. Did anyone do CPR on the scene? Was there an AED used? What was their last meal and when was it? And the actions we're going to take while we're asking all those questions and trying to get the child stabilized, we're going to do immediate airway stabilization. So a lot of you, when we talked about this, were saying check their vitals and check their pulse ox. These things are true, but we really need to make sure that their airway is patent and usable because they're probably going to have to be intubated. We need to stabilize their cervical spine as needed for head injuries. We're going to get that yonker, the biggest one we have, out so that we can suction as much as we can in the back of their oral cavity. We're going to give them supplemental oxygen. We're going to prepare them for intubation. We're going to use an NG or an OG depending on any injuries to the face for decompressing their stomach. And we're going to apply warming methods like a bear hugger. And sometimes we leave them in those for a long time. We're going to check labs like ABGs to rule out hypoxemia or acidosis. We're going to do an ECG to check for arrhythmias, chest x-rays to look for pulmonary edema, infiltrates, or objects they might have swallowed. And then we're going to do their electrolytes to evaluate for shock. To ask about how far they fell. So if it was a fall injury, how far did they fall? And onto what surface? What position were they in when they landed? This is unfortunately where we have to consider the development and the level of the development of the child and the likelihood of their injury when we talk to the parent. Because if a child comes in with head trauma and the parent tells you, and I'm talking about trauma that's affecting their level of consciousness, their pupils, their fontanelles are bulging, and their neurological function is not quite right, and the parent tells you that they rolled off the bed, the likelihood that that is what caused this injury is not high. How is it? A 4-foot high bed and you've got ceramic tile floors? Maybe that's possible. So there are certain injuries that usually get reported immediately to social services and CPS just for evaluation. If you have a child that's coming in with head trauma, you need to know if they lost any blood, if there's any wounds. If the child's awake, we need to know if they're having headache. Have they had nausea? Have they vomited? Then we want to do a secondary survey. Like I said, check for neurological function, level of consciousness. We want to look at their pupils to see if they are equal and responsive to light. We want to do their Glasgow Coma Scale, and again, check their fontanelles. If you see unequal pupils or pupils that are fixed and dilated, that is a neurosurgical emergency, and you have to immediately tell a physician. So the picture that you see right here, it's showing you an example of what we call a coup contra coup. So this child's head has gone backwards and forwards, and this allows the brain to slosh around in that cavity and hit the skull at different points. And then that causes hemorrhaging, breaking of blood vessels that leads to more hemorrhaging. It causes swelling. And their ventricular spaces can kind of get bogged up with the amount of fluid and blood that might be in that area, and they're not able to process it out. Airway management is super important for these kiddos, and we need to put them on a backboard and in a cervical collar. But here's the issue. Not all hospitals or areas have backboards and cervical collars that are specifically made for the different ages of children and the different sizes of children. You can see from this picture that the occipital portion of this little guy's head, it sticks out much farther than you would see in an adult. So when you lay an adult on a backboard and into a cervical collar, with them flat in a supine position, the back of their head and their back under and between their shoulders is usually at the same level. It's level, and they're laying flat. A little kid, that doesn't happen. You lay them flat, and their big old noggin forces their chin down and towards their chest. So then now you've compromised their airway. So the backboards specifically made for infants and toddlers have a space or a dip that's supposed to accommodate their big old chunky occipits. Suction these head trauma kids, but not so aggressively that you can cause increased edema, because that's going to make more issues with their airway after a period of time. And you're going to assess their pulses. Give you an example of how we stage burns. We're going to talk about the risk factors for being burned or getting burned. Suffering abuse or being neglected and having a lack of supervision, those are all high risk factors. The developmental level of the child. We talked about not using walkers. Why do we not use walkers in those non-walking, non-mobile kiddos? Because once we put them in a walker, they can now reach the stove. So we have to look at the developmental level of the child to assess their risk for burns. Younger kids, they have deeper burn injuries, literally because their skin is thinner and they have less subcutaneous fatty tissues. Under age 5, they're more likely to die from a burn that's severe because they have less protein stores in their body than an adult does, and their kidney and immune function is not mature enough to handle the shock from their body trying to fix this burn. Things that you have to do when you have a kiddo coming in with a severe burn. We're going to stabilize them first. We're going to assess their oxygenation and ventilation status. You need to evaluate their lungs frequently. Listen to them frequently because they can develop pulmonary edema over time. We're going to give them fluid volume support using crystalloids like LR for the first 24 to 48 hours. Dextrose, you can add dextrose into their solution if they're an infant, because they probably will need it. So after the first 24 to 48 hours, then you can give a colloid fluid. You do daily weights on these kids because you want to make sure that we're not creating a little bit too much fluid volume in their bodies. And we want to check their sodium and potassium levels. We're going to assess them for hypothermia and warm them if needed. And then when we're cleaning these poor kids, it's so painful. You're going to use very mild soap and cool water. If they have blisters, you don't break them. However, there are times when the burns are so large and severe that the only way to debride them and appropriately clean them to do the wound care is they have to break them. But most of the time, we allow the wound care nurses to do that. So this question, a nurse is providing teaching to a caregiver about acetaminophen poisoning. Which of the following information should the nurse include in the teaching? Include is that pallor can appear as early as 2 hours after ingestion. So they get sweaty and diaphoretic and pale. And that in 2 to 4 hours after ingesting a large amount of acetaminophen. So the risk factors for poisoning is being younger than 6 years old and conversely, being a teenager. Because why? Oh, they think they're invincible, they think nothing can hurt them, and they think they're smarter than everyone else. And they could just be exposed to different things that can cause a lot of bad stuff. So, common ingestions that we're going to see in the hospital: Tylenol, hydrocarbons. That's like lean kerosene, lighter fluid, paint thinner. You might wonder why somebody would be poisoned with these things. It's because they're an adolescent. So they're doing what we call huffing, where you put a rag soaked in gasoline, kerosene, lighter fluid, or paint thinner over your face, and you breathe it in until you get super, super high. These kids come in gagging, choking, lethargic, having tachypnea, they're cyanotic, they can be grunting, and you're going to see a lot of retracting. Hydrocarbons are amazing. Corrosives as well, house cleaners. I took care of a boy who was an obsessive cleaner when he was upset. So that was his stress management, and he went into the middle bathroom of the house that had no window, and the overhead fan was not working, and he used ammonia and bleach together because he didn't know he shouldn't do that. And they found him down in a pile of vomit, and he had massive pulmonary edema and was placed into a medically induced coma for about, I want to say, 3 weeks. He's all right. It wasn't a suicide attempt, but boy, because you're stressed and then you almost die. That's proof that I shouldn't have to clean my house, right? Um, so with Tylenol ingestions, we're going to see symptoms begin 2 to 4 hours after they've ingested it. Then about a day later, improve. And then anywhere from 36 hours to 7 days later, their liver starts to die and then they die. So this is why once we see the post-ingestion symptomatology begin, again, 2 to 4 hours afterwards, we want to get them in and we want to start treatment because we're preventing the hepatic stage of the poisoning. Or acetylsalicylic acid, that's so much fun to say, aspirin, we're going to see cues of nausea and vomiting. Their level of consciousness is going to change. They're going to be tachy, their breathing and their heart rate. They're going to develop tinnitus and have real scant urine production. So aspirin can be a kidney killer. Iron, 3 minutes to 6 hours after ingestion, they can have vomiting, blood, diarrhea. I'm sorry, not vomiting blood, but bloody vomitus and bloody stools. They can have GI pain, and then about 12 hours later, just like with the Tylenol, they improve. And then about 24 to 36 hours later, they develop acidosis, shock, then they're their livers die, and then they die. So iron and Tylenol, very similar presentation and prognosis. Diagnostics that we do for evaluating a child who's had a poisoning or a toxic ingestion, we are going to run a CBC with DIF. We're going to look at their ABGs. We're going to run panels like serum iron, lead, their serum Tylenol level. We want to look at their LFTs. Maybe we'll do their blood alcohol and a drug tox screen. Nursing actions, we're going to monitor them. We're going to notify poison control. And a lot of times, poison control is going to be the ones to guide how we treat. We're going to give them IV fluids. We're going to administer an antidote if there is one. And we're going to do gastric decontamination. So that can include giving them charcoal to force we give charcoal to neutralize the stomach contents, and then we can decompress the stomach via NG or OG and suck all that nastiness out. One thing you guys need to know is that we don't give Ipecac. If you don't know what Ipecac is, it is a wonderful substance that induces vomiting. It is available over the counter. We don't give Ipecac if we don't know what the ingestion is, and we don't give Ipecac if we know that they've ingested a hydrocarbon or a corrosive. Reason being, we don't want them to vomit back up the corrosive substance and burn their throat and their mouth and their airways again. We don't want that to happen. So if you ever see a test question related to Ipecac, we don't use it if we don't know what they ingested or if they ingested hydrocarbons or corrosives.